Dear colleague, welcome to this presentation of the prehistory of psychosurgery and the second part in the introduction course to psychiatric neurosurgery for psychiatrists. This lecture contains little of clinical importance, but it will provide a background and an understanding of how we ended up where we are today, and I also believe that you might find it genuinely interesting. When looking at the archaeological material, it seems as if our ancestors had an almost irresistible desire for making holes in the head in their fellow humans. Trepanations are abundant in many areas around the world and stretches back to the Paleolithic era and survived into modern times, as seen in this video of a trepanation by the Kinsey tribe. But we do not know why they were done. Perhaps the indications were sometimes of a functional nature, like letting out evil spirits causing problems. If we move on to ancient Egypt, then it is a common misconception that trepanations were often performed. In reality, we do not have one clear example of a trepine skull from pharaonic Egypt. Holes in the head were common, but this was a part of the mummification process. The reason why this misconception is so common is partly due to this popular novel about Sinwe, the royal trepanner, by Mika Waltari, and partly due to a lack of understanding among doctors writing about the history of trepanations. Here we have a depiction from the tomb of Keti in Beni Hassan. This was in 1837 interpreted as a doctor treating a patient. In 1919 as a barber surgeon performing some kind of operation. In 22 a probable trepanation. And from 67 and onwards a definite trepanation. But no one read the hieroglyphs above the image, which clearly states that this is a case of shaving of the head. Here we have another example, which was quite recently presented in neurosurgery as a case of trepanation. No detailed information was provided regarding its origin, but it is a well-known scene. And here we see the original image, known as the barber scene, with two barbers shaving the head of Egyptian soldiers. If we then turn our eyes to the opposite side of the Mediterranean, to ancient Greece, then there were cardiocentrics like Aristotle, who claimed the heart as the center of the cognitive faculties, while the brain did only cool the blood. Encephalocentrists like Plato identified the brain as the center of the higher cognitive faculties. Air was inhaled and transported to the cerebral ventricles, where it was converted to pneuma, the substance used for cognition and for controlling the body. This question was at least partly settled with the words of Herophilus from Chalcedon, who worked in Alexandria and performed dissections and vivisections on convicted criminals and demonstrated that the brain is the center for the nerves and the higher cognitive faculties. Another encephalocentrist was Hippocrates, and the first time we meet trepanations in the literary sources is in his works, and then for removal of subdural blood. It is, however, of interest to note that he attributed epilepsy and melancholy to an excess of black bile. And during the Roman era, Galen performed numerous experiments on the brain and nervous system in animals and stated that when black bile is accumulated in the ventricles, it can cause epilepsy or melancholy directly or via its vapors. And Aretius the Cappadocian recommended trepanation for epilepsy in order to exhale these fumes. And in the future, imbalances between different tumors, vapors and temperatures in the brain and ventricular system would often be used to explain neurological and psychiatric disorders. After Galen followed 1,000 years of decline from the Dark Middle Ages to the Renaissance. In the art from the 15th century and onwards, extraction of the stone of madness was a popular motive, but this is probably a purely allegoric motive. In the medical literature, we again meet trepanations in the 12th century in Practica Chirurgiae by Roger of Salerno, where he writes, "For mania or melancholy, a cruciate incision is made in the top of the head, and the cranium is penetrated to permit the noxious material to exhale to the outside. And this is the first time that I am aware of where trepanation is clearly recommended for a psychiatric indication. During the following centuries, we will now and then meet trepanations for psychiatric disorders. The most interesting work here being The Anatomy of Melancholy by Robert Burton from 1621, where he reported several cases of trepanation for melancholy. The development of more modern theories regarding the brain can be said to start with the publication of the Humani Corporis Fabrica in 1543 by Vesalius. And we then see a rapid development, especially during the 19th century, regarding human anatomy, comparative anatomy, histology and pathology. And for our topic, the discovery of electricity is of certain interest, and this field developed rapidly during the 18th century. And this was also the case regarding so-called bioelectricity, and experiments on humans were soon being performed, dead as well as living. Electrical simulation of the brain on living animals was done as early as 1809, and the first experiments on alive humans around 1870. Even though detailed mappings were done in this manner by Ferrier and others, the most important technique for mapping of the human brain was cerebral localization, where you look at the symptoms of the patient and later at autopsy correlate these with changes in the various areas of the brain. And then we arrive at the birth of modern neurosurgery in the end of the 19th century, when cerebral localization, general anesthesia, and antiseptics and new techniques made intracerebral procedures possible. An early neuropsychiatric procedure was trepanation with opening of the dura and CSF drainage, introduced in 1899 by Clay Shaw, lecturer on psychological medicine. It was mainly performed for general paralysis of the insane, that is neurosyphilis. And general paralysis is also of importance for our understanding of the future development, so we need to have a closer look at this. Neurosyphilis with the dementia paralytica, more commonly known as general paralysis of the insane, was a severe health problem in the early 20th century. These patients occupy 10% of the bed in the psychiatric wards, and 80% of them would soon after admission suffer an often horrendous death. It was known as the Great Imitator because of the difficulty of differentiating it from other psychiatric disorders. While we today consider this infectious disease to be in the realm of the microbiologist, neurosyphilis was in the pre-antibiotic era perceived as a mental disorder of central importance in the field of psychiatry, a field which in many cases was the responsibility of the neurologist. The first effective treatment was introduced by the Nobel Prize winner Julius Wagner von Jauregg. He discovered that by inoculating the patients with malaria-infested blood, a high rate of remissions could be achieved and the fertility rate decreased to around 5 to 10%. This soon became the standard treatment and remained so until the introduction of penicillin in the mid-40s, but was in continuous use until the 70s. But let us now return to the surgical procedures. The first intracerebral procedures were done by a Swiss psychiatrist, Dr. Gottlieb Burckhardt, in 1891. He operated 6 schizophrenic patients with removal of various cortical areas, chosen quite randomly and with very limited success. However, at this time, the interest had already started to focus on the frontal lobes. In 1910 in St. Petersburg, the neurosurgeon Ludwig Pusep, in collaboration with the neurologist Vladimir Besterev, performed the first frontal procedures, cutting of parieto-frontal connections in 3 patients with poor results. But this was not reported until 1937 as a consequence of the introduction of the leucotomy by Moniz, and hence Pusep's report had no importance for the future of lobotomy. Thus, according to the traditional accounts, nothing happened in the field of psychosurgery during the period between 1891 until the introduction of the leucotomy by Moniz in 1936. But this is not completely true, as we will soon find out. Moniz was, beyond doubt, a very gifted man. As a neurologist, he created a name for himself with his pioneering work in cerebral angiography. He was here actively pursuing the Nobel Prize, but in the end he fell on the finishing line, partly due to an issue of priority. This was a grave personal loss for him, and he would therefore pursue the Nobel Prize for his leucotomy with even greater zeal. As was not uncommon during this period, his patients suffered mainly from psychiatric disorders. His views on such conditions were of an organic nature, and he considered the current treatments to be unsatisfactory, with, as he wrote, the exception of malaria treatment in general paralysis. It is therefore not surprising that he would now investigate treatments of a more organic nature. It has been difficult to reconstruct the path leading Moniz to the frontal leucotomy, especially since he himself was very reluctant to acknowledge any influence. Further, no tests were performed in animals, and the technical preparations were allegedly limited to sticking a pencil repeated times into one single human brain until a satisfactory approach was found. According to the traditional narrative, Moniz was inspired by the presentation of Carlisle Jacobson on prefrontal lesions in chimpanzees at the Second International Neurological Congress in London in 1935. A few months later, he performed the first operations with the help of a young neurosurgeon, Almeida Lima, and in 1936 he presented his findings in the first 20 patients. This story was, however, not endorsed by Moniz himself, who reported that he had informed Almeida Lima of his idea already 2.5 years before he heard the presentation of Jacobson in London. And this places us in Paris in 1932 at a meeting of the French Academy of Medicine. Here Moniz presented a paper on angiography, and immediately after him Maurice Ducoste presented his cerebral impalludations, and these papers also appeared together in published form. Here Moniz would have learned that more than 100 patients with general paralysis and a very large number of patients with other psychiatric conditions, including schizophrenia and mania, had been operated with favorable results using injections into the frontal lobes. Further, that this had been done without any serious complications. And this is the missing link explaining how Moniz could embark on the path to leucotomy on such loose grounds. Ducoste was a psychiatrist working at the asylum of Villejuif in Paris. After some animal experiments, he performed in 1920 mechanical lesions with a steel wire in the frontal lobes in schizophrenics. Later also in mania and depressions. In 1925, he started with injections of malaria-infested blood and other substances for neurosyphilis and other conditions. And in 1933, he reported a total number of 268 patients, and in 1940, 1,000 patients. A trepanation was performed at a point 10 cm behind the orbital arcade and 2 to 4 cm lateral of the midline, and a needle was inserted about 4.5 cm into the frontal lobe using a special device, and here up to 5 cubic centimeters of blood or other substances was injected into one or both frontal lobes. And this could be repeated up to 12 times in staged procedures, which must have created significant lesions in the area. In total, the group of Ducoste presented 16 papers and monographs between 32 and 40, and the procedure was also performed by some other groups around the world. So, Moniz performed his first operations in 1935, and in 1936 he presented the leucotomy in 20 patients, and he published his papers in 6 different languages, which he sent around the world in order to establish priority. The first leucotomies were made using the same entry point, target, depth, injection technique, and indications as Ducoste, who had by then presented more than 500 patients in 5 publications. The only difference was that Moniz used injections of alcohol and injected both frontal lobes in the same session. Only later did he increase the number of injections before introducing the core method with mechanical lesions using a leucotome, and even later multiple burr holes on each side. Ducosti initiated the Battle of Priory in May 1940, but 1 week later Germany invaded France, and after this we hear no more of Ducosti. The future development of the lobotomy occurred mainly after the war and in the USA, where no one knew of Ducosti, who mainly wrote in French. Moniz never acknowledged the work of Ducosti with a single word, and received the Nobel Prize in 1949. The lobotomy spread around the world, and in relation to population it was most common in the Nordic countries, followed by Great Britain and the USA. It is not difficult to understand that lobotomies were tried for psychiatric disorders. What is difficult is why a rather ineffective procedure with a high mortality and a very high morbidity became so popular. But likewise, it is today difficult to imagine the horrendous state of the psychiatric care before the introduction of antipsychotic drugs in the 50s. Many asylums were overcrowded with severely ill and sometimes uncontrollable patients. To take USA as an example, about half of the beds in the healthcare system were occupied by psychiatric patients, and the budget allotted for these patients was seldom sufficient to provide a dignified existence. Any suggestion on how to improve the situation would have been welcome. And no possible therapy was too strange to be considered, or too dangerous. In the 30s, insulin coma, metrazole convulsive therapy, and electroconvulsive therapy were introduced. It is true that these treatments helped some patients, but most patients were not candidates due to their condition or due to the high cost of these personnel-intensive treatments. But these cures demonstrated the willingness to try anything that might work, even if dangerous. And this is especially clear regarding other forms of surgery such as steroidectomy, castration, and clitoridectomy. Most well known is perhaps the work of Henry Cotton, who hypothesized that psychiatric disorders were caused by focal infections and who performed extensive dental removal and colectomies. Even though the mortality was high among his patients, he was still a respected member of the medical community. The leucotomy of Moniz was crude and imprecise, and it is unlikely that this procedure would have become widespread. However, Walter Freeman, working with the young neurosurgeon James Watts, started performing leucotomies in USA already in 1936, but the effect was rather poor, and hence they started to make larger and larger lesions, which resulted in larger and larger side effects. For that reason, they developed the ventriculography-based standard lobotomy, making the procedure less arbitrary. They did also abandon the leucotome and started to cut frontal connections using a blunt blade. Here we see Walter Freeman directing Watts regarding how to make the incisions. Further, in 1942, they published a monography, Psychosurgery, where Freeman provided a scientific rationale for the procedure, which was essential for a wider acceptance of lobotomy. He defined the goal of the lobotomy as to cut the connections between the dorsolateral thalamus and the frontal lobe, and this book resulted in a major surge in the interest for lobotomies. The new procedures were based on an initially very limited but gradually increasing understanding of some of the mechanism of action behind lobotomy, an understanding where the most important step was the introduction of the circuit of Papez. When speaking of lobotomies, it is important to realize that a large number of very different procedures were developed and used. This development was driven by a will to improve the effect and to reduce the side effects, and it was found that this could, to some extent, be achieved by focusing the lesion in the medial and deeper part of the frontal lobe, overlying the orbita, that is, the orbitofrontal cortex. The most well-known procedure was the ice pick lobotomy or the transorbital lobotomy, developed by the Italian psychiatrist Mario Fiamberti. This was promoted by Walter Freeman, here seen performing the procedure. The most important reason why he endorsed this method was probably that it could be done by the psychiatrist himself without the need for a neurosurgeon. He toured the country in his lobotomy mobile and performed about 10% of all lobotomies in USA. He would do up to 25 procedures a day and teach other psychiatrists how to do it in half a day. And it is recorded that one of his disciples did actually perform no less than 75 operations in a single day. The transorbital lobotomy looks terrible, but it was probably an improvement compared to the standard lobotomy, both concerning the effects, but especially concerning the side effects. When reading the modern literature on the history of psychiatric neurosurgery, it is not unusual that less well-informed writers assume that the most famous persons behind these procedures were neurosurgeons. In reality, they were most often psychiatrists, or neurologists specialized on psychiatric disorders. To take Walter Freeman as an example, he is not seldom referred to in the literature as a neurosurgeon, but he was in reality a so-called neuropsychiatrist, that is, a neurologist specialized in psychiatric disorders, which was common in many countries in the early days of these specialties. He was also for a period the president of the American Board of Psychiatry and Neurology, which meant that no psychiatrist in the USA would get their specialization recognized without his signature. The second most experienced lobotomist after Freeman was probably the Japanese psychiatrist Sadao Hirose, here seen in visiting the well-known psychiatrist Gösta Rylander in Stockholm. It is also interesting, as a sign of the spirit of this period, to read the paper of the Norwegian psychiatrist and head of Norway's largest mental institution, Ernulf Ödegård, who wrote that psychosurgery can be easily performed by the psychiatrist himself with the tools he might have in his pocket, and strangely enough it may be harmless and effective. Concerning effects and side effects, it's very difficult today to draw any certain conclusions, but I think that it's safe to say that generalizations are of limited value. There are many different forms of lobotomy. There are varying skills in the technical performance. It was used by skilled neurosurgeons, by psychiatrists with half a day of training, and by general surgeons on the lunch break, and so on. It was used for many different conditions, actually the whole spectrum of psychiatric disorders. In some patients, a good outcome was achieved with limited negative side effects. Some patients received no benefit but major side effects or death. In the great majority of patients, the trade-off between positive and negative effects was not acceptable by today's standard, but in some of them it was with yesterday's standard. The side effects of lobotomy were well known in the medical community since the first beginning, as seen at the presentation of Monet's patients at a meeting in Paris in 1937, where he was criticized by Sobral Cid. Loss of the spark of life, disinhibition, reduced initiative and planning skills, apathy, cognitive decline, and so on. However, some, such as Moniz, Freeman and others, considered this a price worth paying and chose to downplay these and focus on the positive effects. Due to the side effects of lobotomy, we see a development towards more selective procedures. In 1949, William Scoville presented the supraorbital undercutting, and this was further developed by Jeffrey Knight into the restricted orbital undercutting, and in the early 60s into the stereotactic subchordal trachectomy. The open cingulotomy was introduced in 1948, and later done stereotactically, and also combined with the subchordal tracheotomy into the limbic locotomy. In 1949, Talleyrand introduced the open capsulotomy, which Lars Lexell converted into a stereotactic procedure in 1952. We have thus arrived at the early stereotactic era, which is the topic for our next lecture. And with that we end the present lecture. Thank you for your attention.